we'll be happy to answer. Dr. can also answer. If I am required to answer, I am also here. I can see that some people have also joined online through Zoom.
If those on Zoom have a question, please raise a digital hand. And here, of course, anyone can raise a hand.
The Hindu.
Hi, Doctor. Hi, Dr. Anjana. How are you? It's good that we have this data finally. But I just have an initial question about you mentioned about the shorter duration of diabetes. What are the ranges that we basically looked at? What are the ranges that we have looked at in terms of duration of diabetes in patients?
Do you want me to answer that, or right?
Yeah, you go ahead.
So we have durations that are of different ranges, Ramya. So we have less than 5 years, then we have 5 to 10 years, and then more than 10 years. So the risk is for more than 10 years. And as you get lesser and lesser from that 10-year mark, it gets better and better. So for 5 years is better.
Perhaps we can explain it this way, Ramya. First, when people are diagnosed, they are perhaps a bit more worried about their diabetes, and as time goes on, as in any chronic disease, asthma or rheumatoid arthritis, diabetes, anything, they tend to kind of neglect after some time and give up. Some of them get depressed, some of them just don't care anymore, I can't do this anymore. So that's one thing. Second is that it gets more and more difficult to control with duration. Because what happens, your beta cell function is going down. So when you're diagnosed, you'll have some beta cell function. So with one metformin or something, you'll be diagnosed. As you go on, a second drug, third drug cannot be needed. And unless you're going regularly for follow-up, they will not intensify the treatment. Clinical inertia will set in, and the control will get worse. So the danger, and that's the time when the complications also will set in. So I think those with longer duration need to go back more often to the doctor to screen for complications, and I think that's one of the things which.
So you would say go back to the doctor every 3 months?
So I think Anjana published a paper on this about 5 or 6 years ago, or maybe a little longer, where we looked at, because we keep saying come back 3 to 4 times a year, but there are costs involved, whether it is government or private. Even if the government, they have to travel, go there and so on. So we did a study where we looked at those who came regularly for follow-up, at least 3 times a year, compared to those who came 1 time a year or less than a year. Within 9-year period of follow-up, what we found was that those who come regularly for follow-up, they had a 50% at the beginning. It's a very large series, about 2,000 patients in the clinic whom we followed up. And what we found was at the beginning, nobody had any complications. They ruled out all those who already had complications. And then over a 10-year period, when we followed them up, we found that those who simply came for the follow-up, they had a 50% lower risk of both eye disease as well as kidney disease, which is very, very significant. And if you calculate how much more for those 2 extra visits that they spend, it's nothing. Because for a review visit, you really need a HbA1c and a blood sugar and a consultation or something. You're really not going to spend a lot of money on that. But when they don't come, the A1c keeps on rising. So suppose it's at 7, only 30% have achieved 7. But let's say they reach 7, then they won't come. Now I'm under control, I don't have to go. It will become 8, they won't come back. It will become 9, they won't come back. Then when it reaches 10 or 11, they become sick. They develop urinary infection or something, they become weak, then they come running. They've lost all that time, that much time, the beta cell function is going down, complications are the seeds for complication are being sown. So that is a golden period, and this study points out very clearly, because earlier they'd say it's all clinic-based data, city-based data. Now it is telling us the whole country's data, and both in urban as well as in rural India, even things like physical activity, the things which people should be doing, taking on very simple things, sugar, blood pressure, cholesterol, cannot take on many complicated things. And using generic tablets, you can get all these under control. And in spite of that, it's not happening. So it's a wake-up call. And even during COVID, you know that it's people who did not have that sugar under control who had all the risk. So suppose, heaven forbid, like COVID or COVID again, 4th wave or something else happen, it's these people who are going to be hit very badly.
Absolutely.
Absolutely.
Thank you, Dr.
Yeah, go on.
I don't want to hog this, but one more question. I'm intrigued. So you said initially there were 4,000 samples from each state, but only 1,200 urban and 2,800 rural. Was this sort of a deliberate choice to pick more rural patients, or was it just?
Give 1 minute. So how it works, Ramya, is that we have to base this based on the population distribution. So we have picked, if you take a state, we have to pick based on geography, so across. We have to base on population size, population distribution, and socio-economic status. So we have to check all of these things. So we use the census data, which is the base data for all the sampling, and based on that, using the NFHS3 base, we have built all these parameters which I just told you, population size. So India's distribution of population, urban and rural, falls in a similar manner. We have also sampled in the same.
It respects the basic distribution of population.
Yeah, if you actually lay this on a census population, age-wise, male, female, it will lie exactly on, because it is
exactly on topic, because we use the same distribution. So.
Thank you.
Understand the findings of the study. How do you think what policy implications may have on a larger scale, as you know, the burden of non-communicable disease rises, and there is a lot of emphasis nationally on very about these things.
Policy implications, go ahead.
So, did you say, sorry, I wasn't able to understand, what is the
No, so the question was, in the light of the study, what are the policy implications since we are finding such poor control? What will be the policy implication? What would we tell the government if they ask us, okay, what do you want us to do after the study? What will you tell them?
Yeah. So that is a very, very important question. I think something that all the press should ask. What is it that the government should do? The need of the hour is education. The need of the hour is screening. The need of the hour is availability, accessibility of medicines. The need of the hour is being able to regularly monitor these patients to see that they actually achieve this control. People think, Rahman made a very, very important point when he said, people get their A1C under 7 once, and then they think, oh, it's under control. But it won't stay under control forever unless you take that effort. And I think that is what needs to come as a policy implication. What should the government do? The government should encourage physical activity starting from schools. The government should encourage healthy eating, make available fruit and vegetables cheap so people can buy and eat. The government should educate that someone with diabetes has to visit a doctor every 3 months. Maximum within 6 months. They have to see a doctor twice a year. You have to do the sugar test. You have to check your blood pressure. Check your cholesterol. It's important. Keep it under control. Educate about the numbers. Make people aware. Self-monitoring. Okay, you see the doctor once in 3 months, once in 6 months. But what's happening every day? You have to be able to monitor and check. The self-monitoring so poor. If you are able to check and monitor, you can control it. Very, very small, simple things can be taken up by the government and done to make large effects in a population at large.
So there are two as the pandemic influence study. Now this study took about 10 to 11 years to do because it had every nook and corner, including the northeast, every state, and only the islands and Jammu and Kashmir are left, which is now going to start in the next phase of India. Otherwise, all the 30 states are over. So a lot of this was done before the pandemic actually kicked in. And so it did not actually affect our study to a large extent. Of course, there were a few months when it was at its peak, when we had to stop all work, but then we quickly picked it up again in the states where it was not, the pandemic was not very active and so on. And so to answer your question, it did not impact the study in a way that we had to give up the study or get a lower response rate. We had to answer your question about the quality. This study is one of the most quality conscious studies. So we had teams from ICMR making field visits, expert teams, to every state in the country where it was studied. and they spent a day or two going through the records, going through the blood samples, how they collected, going and asking the individuals how they were taught about the sample being taken. It's a pakka study, and that's why it's getting published in journals like Lancet. And so the quality measures which are built in, you can write books on it. In fact, they have SOPs written, and this study can be a model for many other studies. Because as you know, sampling a country like India with so many states, so many languages, so many cultural differences is a nightmare. But we somehow managed to do it. To answer your question, how the newly diagnosed cases were managed, again from the beginning, ICMR made it a mandate that every new case which was there, every new patient who was diagnosed with diabetes, now remember it's a screening test, and so the test may show that somebody has diabetes. That's not a diagnostic test, it's a screening test. So what we did was, each and every person who was diagnosed was taken to the nearby doctor, very often to the government places, where at least an initial treatment was started. They were also asked to, same thing for blood pressure also. So if they had very high cholesterol or blood pressure or sugar, we ensured that there was a continuity of care. Number two, a health card was given to them, and all this is of course done free of cost as far as the participant is concerned, and so that is given to them. Number three, we gave tips to them. So how to, what diet to take, what exercise to do, a health card, and at the back of the health card all these tips were given. Even if they had pre-diabetes, how to prevent diabetes was given to them. All this was given to them. On top of all that, every sector that we survey, whether it's a district or the whole state or whatever, to the district medical officer in that region, we said this is a study conducted by Government of India ICMR, and these are the new cases which we have picked up with diabetes in this area, and please follow up these people. So that was also done. Normally in an epidemiology study, they just screen and then they leave it, and therefore there are ethical concerns. Because of that, the government was insistent, and the ICMR is insistent, that this should be a model study. So every single person, we went back and did that. In fact, in the next phase of that, now that 10 years are over, Tamil Nadu and Chandigarh and the Maharashtra and Jharkhand, where we started first in the phase one. So those are now complete 10 years. We're going back to those states where it's over and trying to pick up those people who already had diabetes there and seeing what happened to them and follow them up and look at whether some of them unfortunately might have died. So we are trying to look at all that. So it's much more than just a diabetes study. We have extensive data coming out shortly on diet, on physical activity in different parts of the country. This is just the quality thing, but there is much more data which is going to come out. This is like a treasure house of information. The fact that it's taken 10 years, it's been well worthwhile. And that's why INDIAB is so highly rated.
He's asking whether the report has been submitted to the central government and all. So the paper has just come out today, sir. And yes, ICMR does have a mandate for us to make reports. Not only should it be available, it should be publicly available to researchers, government organizations, states. So each of the state data has been sent to individual states. Tamil Nadu state was submitted.
There is a PI for each state, you can tell them. So in each state there is a principal investigator in that state, usually from a medical college or from the government. So that person takes a responsibility. In many of the states, they then hold dissemination workshops to disseminate this data. And even the prevalence of diabetes itself, when we earlier had the data at ICMR itself, we have had dissemination workshop where the DG ICMR, Ministry of Health and others are invited, WHO and all the health secretaries and others were all invited, and they were all given copies of the report. So we give it back to the respective governments so that they can decide what to do for a particular state, because health is a state subject.
And in Tamil Nadu,
take the initiative for implementing this.
Ramya, I had another question?
sorry, there's someone asking a question here.
Can you use the mic, please?
Yeah, just use the mic so they can also.
The government should take the initiative.
Yes.
Telling the people.
Yes.
Do you have any tie with the government? Private hospital having tie with the government?
We don't have the current time. Our collaboration is funded to do the study. That's all. We don't have any other collaboration with the government to do a public-private partnership. But the government should take such initiatives Because as you saw, there's so much of private healthcare. So there should be dissemination strategies where government takes small messages, walk 10,000 steps, eat fruit. They used to have that anda thing. The healthy, like that, government can take each of the things and.
They are already taken actually, but.
No, but if you take, the government initiatives are very, very narrow. For example, you take Chennai City. Chennai City has some good initiatives in terms of, let's say, physical activity. They do have, this road blocking for traffic so that pedestrians can walk, more people can walk, etc. But when you take India as a whole, it is very lost. And only very certain states, their infrastructure and government health and their ability to disseminate is coming out itself. You can take 3 or 4 only in the whole country. The rest of it is completely lost.
I saw another report.
No.
Some newspaper. Yes, age group also does make a difference.
Age
group.
Age group, yeah.
After 20 years,
Yeah.
they have more control over diabetes.
Actually, it's the other way around. Okay,
Yeah.
because it's the other way around. So for diabetes, it is one way, and it is for BP, it's another way. So let me explain this to you. For diabetes, if someone gets diabetes when they're 20 years old, okay, the reason they're getting that diabetes is most probably either because they're overweight, but mostly because they have some defect, pancreatic defect. Okay, so this leads to a very severe form of diabetes. So usually these people have difficulty in control, number one. Number two, young people are either working, going to college, have jobs, have stressful lifestyles. So the ability to do that exercise, keep the diet, take the medicine, go see the doctor is much less compared to a retired person. Okay, so 65 plus, they have more time, they're retired, they are more, have more energy, go see the doctor, do things in a more, this thing. So that way for glycemic control, the age is opposite. Younger the age, worse is the control. But for blood pressure, it's the opposite. That age is a naturally factor that increases your blood pressure. So as you age, higher your blood pressure. So for different things, it's different.
Couple of things to the gentleman who asked. We do work with the government, may not be in in a private partnership, public partnership kind of thing, but in all their committees where they are tackling non-communicable diseases and where diabetes inputs are needed, they often consult us. And so I sit in both central government and committees, as well as in the state government, Tamil Nadu government also, where they call us and they ask us for opinion. For example, when COVID came, how should diabetic patients be managed? I was part of that committee along with the government doctors. So we work very closely with the government and all this. And in all our rural work, for example, where we have adopted more than 40 villages, the health secretary and the government of Tamil Nadu has allowed us to work in those villages to help the villages to keep their sugar under control. So we do work quite a lot with things. The last point about the young age, why these people have more, why they get at young age, apart from the obesity which Dr.R.M.Anjana mentioned, genetics is usually stronger. Because if you don't have a family history of diabetes, father or mother, you tend to get it when you're 40, 50, 60 years old. But if you have strong family history, father and mother are diabetic, then the gene becomes very strong. Then you get it at a young age, and then it becomes very difficult to control because you have a very strong gene effect, plus you have obesity. And that's why it's very difficult. Ramya had one more question. She raised her hand. Ramya?
Yeah, hi, Doctor. So I'm just wondering, I'm trying to understand whether the results that you've seen are irrespective of the quality of care in hospitals, because as you very well know, there is a range of medical care that is available in India, but in places where you might expect a sort of a lowering of quality of healthcare, probably in the Northeast, we see rather good results, good control. Is this, basically, are you trying to say that control of diabetes depends, or even non-communicable disease, metabolic diseases, depends largely on the individual, the patient, with the health services systems to support his recovery, etc.?
I think it's both, Ramya, because the individual also has to take care. But then if there is no healthcare facility available, if they go to a state where our state is different, Kerala is different, Goa is different, Sikkim is different, there are a few states which are very different. But there are others where the primary health center metformin is not available even if they go. Insulin is not available in many places. So that also influences the poor people. They have to go and get the free medicines only. In some of them, there's no doctor available there. So that also makes a difference. Northeast, there are